misconception that people have TMJ is a misconception because everybody has TMJ, right? Everybody has a TMJ. And what does TMJ stand for? Temporal-mandibular joint. And what do we know about the temporal-mandibular joint? Jade, what do we know about the temporal-mandibular joint? What bones are involved in the temporal-mandibular joint? Oh, and by the way, you don't have a muscle exam, a muscle quiz. That was something else that I was going to do, but I'm not doing it. Okay? You're all happy?
Yes.
Not next week either, you're saying?
I was going to do it next week. I don't know. There's a lot of,
We're behind already.
there's a lot in this semester, and I hate to take up some time. I mean, even though it'd be good for me to know, I don't know, maybe I'll sneak it in somewhere. I don't have to. But anyway.
Don't stress it.
But anyway, let's talk about the TMJ, right? So what do you know about the TMJ, Jay?
So it's the bones of mastication that connect. I hear the time
Can
for
you project a little louder?
the bones of mastication.
Okay, the bones masticate?
Well, no, not.
Okay, so there are bones involved in a joint, right?
Yeah.
And what are the bones that are involved in this joint?
Your pterygoid.
That's a muscle.
Oh,
You guys follow what I'm asking? Chris?
Like man.
Yes, the temporal bone and the mandible of the jaw.
Okay, so the temporal bone, what's specifically on the temporal bone?
The mastoid process?
Yeah.
The mandibular fossa.
The mandibular fossa, and what on the mandible?
Something
Oh.
condylar.
Muscle quiz coming up. Bone quiz coming
Well,
up.
that's what I said.
The mandibular condyle, right? Right? Okay, so we have a mandibular fossa, we have a mandibular condyle. There's an articulation. What's an articulation?
Where two bones meet.
Yeah, that's when two bones come together to form a joint, and an articulation is usually held together by ligaments. There's a lot of ligaments associated with the joint itself. We're not going to go in detail about them, but we're going to give you some information about the TM. I'm sorry? It's a modified hinge joint. Yes, good. Why do we say, if you guys, can you see the, hello? Can you see the, you can see the screen? How can we move this so you can see the screen? Lift it up. Up here? Yeah. Lift it
Yeah, can you
down
just hold
here
it?
and move it this forward. Higher like here. Hold on, Casey, we'll fix it.
Yeah, just
We'll
hold
fix
it.
it.
Just line.
I'm sorry, because I want you to see.
Yeah, when I was doing it last semester, I had the computer up on the front desk there.
It's for them to see?
Yeah. All I did was tilt the screen back. Can you see that?
Yeah, that's.
Can you guys see the slides?
If it's held right there.
Can you see?
Sounds like very.
Can you see, Casey? Steven's calling somebody.
That's not in your way.
Steven, who are you calling?
That'd be call me.
What? Yes.
That's not good. Yeah, that looks good though.
Email with this lecture on it, if they want to follow.
My computer?
They got an email with this lecture PowerPoint attached to it, so they don't need to necessarily see this screen.
Oh, okay,
They can
okay.
follow along.
All right, so I'll just say next slide. All right, all right.
Is that going to get in your way? It's also a sketchy spot. I don't want to put that there.
Yeah, so guys, can you hear me? All I'm gonna say is next slide, okay? Can
You
you
guys
guys
have the PowerPoint. To email them to you, so she's just gonna say next slide, and then she's going to the next slide.
Okay?
Yeah.
Okay,
Yeah,
okay,
yeah,
Alright.
my computer audio is like, something's wrong with it.
all right. So we're gonna see next slide.
Guys, we're going right up here. There we go, boys.
Okay, thank you. All right, so we said, what's unique about the TMJ, temporomandibular joint, is that it's one bone, but it's two joints, right? It's one bone, but it has a joint on the right and it has a joint on the left. So, between these two bones, between the temporal bone and the mandibular condyle, there is a disc, a fibrocartilaginous disc. And what do we know about fibrocartilaginous discs? What do we know what's the difference between a fibrocartilaginous disc and a hyaline cartilage? Fibrocartilage and
Very strong.
very strong.
Strong.
Very strong, don't you think it has to be? Right? How many times do you swallow? How many times do you chew? How many times do you bite?
She's less susceptible to wear and tear.
Right? So this is it has to be. It has to be. We have one joint, but we have two joint compartments. One joint, but two joint compartments. So where's the superior joint compartment? Looking at this picture, where is the superior joint compartment? Between what?
So the temporal bone and the disc.
Andrew?
Between the temporal bone and the mandibular condyle.
Between the temporal bone, so the mandibular fossa, right? And the mandibular condyle.
Yeah.
I'm sorry, not between the mandibular fossa, between the temporal bone and the mandibular condyle, right?
Yeah.
That's the superior joint compartment. Where's the inferior joint compartment? Between the mandibular condyle and the disc. See, there's a disc. There's a disc in the middle, and there's a superior joint compartment and an inferior joint compartment. So, even though this is where, I should have said, let me go back, Andrew, because what you said, and I said, yeah, that's right. Between the mandibular fossa and the disc, between the mandibular fossa and the disc is the superior joint compartment, and between the disc and the mandibular condyle are the inferior joint compartment. Okay, so we have two joint compartments, superior joint compartment and an inferior joint compartment. Yes,
So just one more time, so it's between the temporal bone and the disc.
between the
and then-
temporal bone and the disc, and
disc
between the
and
disc and the mandibular condyle. Okay? Because the bone just sits between the fossa and the condyle.
So is that disc similar to like a sinoid labrum where it helps to keep the condyle in the joints?
Yes, it helps keep the condyle where it needs to be, but more importantly for here, it's for shock absorption. Okay? So we have a superior joint compartment and an inferior joint compartment. And what Andre said is absolutely correct when we talk about a TM joint. A TM joint is known as a modified hinge joint because we just don't open our mouths up and down. Right? If you don't believe me, look at a hippopotamus when they're eating, or a giraffe. So when you open your mouth and you have all these excursions. So you have and an elevator activity, a depressor activity, and you have lateral excursions, lateral and medial excursions. So your jaw moves back and forth, and moves up and down. Okay, it doesn't really move circular, but you can kind of move your mouth any way you want, the mandible. And that's the problem with mandibular movement, because you can't control that when you sleep. Right? You don't know what happens to your jaw when you sleep. So, when we talk about muscles of mastication, and those are the elevator muscles of the jaw, what are they? Kyle, what are the masticatory muscles of the
Masseter and pterygoid.
the
Masseter
masseter?
and pterygoid.
Which one? Medial pterygoid and the anterior temporalis. Okay, not the posterior temporalis. Posterior temporalis causes the jaw to retrude. So we have these lateral excursions. We have these elevator up and down, right? Sagittal plane movements. And we have this retrusion and protrusion. So when we talk about retrusion and protrusion, we're really talking about what's happening in the mandible. So you could bring your bottom teeth in front of your top teeth, right? You could do that. You could slide your bottom teeth in front of your top teeth. You could even somewhat retrude the mandible. So we have those motions associated with the mandibular movement also. Okay. So what are some causes of temporomandibular joint dysfunction? Or temporomandibular dysfunction? Trauma, somebody hits you in the jaw, or you have a whiplash where your head goes forward and backward and the jaw slides because you're not anticipating this accident to happen. You could have a malocclusion, which causes problems with the joint. Does anybody know what the difference is between an overjet and an overbite? No?
First one?
I'm guessing, but an overbite is like a natural position of the teeth, but overjet is an extreme overbite.
Well, an overbite, the teeth shouldn't cover more than like a third to a half of your top teeth over your bottom teeth. But if over 50% of your bottom teeth are being covered with your top teeth, with your maxillary teeth covering the mandibular teeth, then you have an overbite. But an overjet is, when you think about a jet plane, coming in like this, a jet flying, an overjet is something, like Bugs Bunny. Before everyone got braces, now you very rarely see it, because every time there's a kid that's 12, they put braces on them. And the overjet was when the teeth don't come like this, but they go out like this. A terrible term they used to use for it is buck teeth, So that is known as an overjet. Okay, so that could give you an occlusion problem. Bruxism, yes.
I'm sorry, can you just go one more time with the overjet?
Yeah, an overjet is, for lack of a better term, buck teeth. Okay, so when the teeth are situated not in this plane, but more in this plane. So they're coming out. I'm sure you've seen, especially older people that have not had braces, like I said, or in this country at least, kids get braces at very young ages, whether they need them or not. And sometimes, that's only my opinion, but that's not, Because sometimes, when you think about it, a little overbite or a little overjet kind of gives you character, If you think about some of these, any of you remember Robert Redford? In his young, he's old now, but in his young days, he had this very unique smile. He had a slight overjet, and it wasn't corrected. What made him unique? I'm trying to think of some other people. There's a lot of people, when I look at them, I say, well, I know they didn't have their teeth corrected. And it just makes their smile just a little bit more unique. Okay. Makes you who you are, right? Okay. Also, poor posture. If you have a forward head posture, so if you all sit there and you put your head in a forward posture, exaggerate forward posture, what happens to your jaw?
I noticed that like my tongue placement moves down a little bit more than my jaw.
Just starts to pull back.
Your jaw retrudes.
Yeah.
Your jaw retrudes. Your mandible retrudes. So with mandibular retrusion, you get compression of the joint. Okay, so these are all things that can happen, or that can cause you to have a problem with your temporomandibular joint.
What did you say, bruxism?
Oh, I didn't mention bruxism. Bruxism, does anybody know the difference between does anybody know what bruxism is? It's a clenching and a grinding. More so the grinding and clenching. So when do you do this? When do most people do this?
Sleeping,
When do most people do this?
sleeping.
When they're sleeping. Sometimes you're in another room and you hear, I mean, when these people are really that bad, that's what you hear, yes.
I think I heard like a case lately that like a lot more people are grinding their teeth because of the mask.
A lot more people clench because of the mask.
Yeah, it's something I'm hearing lately and stuff.
You know, that'd be an interesting thing to see. That'd be an interesting thing. I think the masks are gonna show us a lot of things over time, you know, that we haven't seen. The masks also do, you know why? I kinda, sorta, well, not that I don't agree with you, but I haven't seen any studies on it, but I'd like to see a study on the fact that the mask keeps you in more of a forward head. You know, because generally when you wanna look down, or when you look up, you kinda jut your head. Or when you look down, you just don't look down because the mask rides up. So you might do this to look down, so you're more in a forward head position. And if you're in a forward head position, what happens? You get mandibular retrusion, you get TM retrude, the mandible retrudes and you get compression. Okay? All right, so bruxism, the difference between somebody who bruxes and somebody who grinds, bruxism is really associated with that grinding or clenching while you're sleeping. Okay? As opposed to grinding, they use the words interchangeably though. But as opposed to clenching, when they think of clenching, you think of something more active when you're awake. Right? You're stressed, you're driving, you're holding on, you're anticipating some accident, something coming, you clench your teeth, right? Or some people just clench their teeth normally. Last semester we talked about the fact that you may be stressed, and then when you wake up, because you're clenching, when you wake up, what do you have? A headache, right? Why do you have a headache?
From that increased tension in those masturbatory muscles.
Right, because you have tension that's created overactivity, hyperactivity of these mandibular elevators. So where's the anterior temporalis? Here, right? Where's the mandible? Here. Remember how we palpated where the mandible was and where the medial pterygoid was? Where's the medial pterygoid? Under the angle of the mandible. So one of the evaluative things or assessments that you use when you palpate, when you work with a patient, is you go over and you look at a patient, you look at their face, you place your hands on the temporal area, and you apply a little pressure and say, tell me if you feel any discomfort. And you press there, or you press here, or you press, and then usually, not usually, but a lot of times when you go under the mandible itself, that person will jump and say, oh, I didn't even know that was there. I didn't even know that was that painful. Okay? So obviously there's pain. Obviously there's pain associated with temporomandibular joint problems. There can be ringing in the ears and a clicking and a popping and a fullness. And I'm talking about the fullness that may be associated with, you ever been on a plane and you want to yawn because you want to pop your ears? So that kind of a fullness. The ringing can be associated with a couple things. You don't have to know this, but there is a muscle known as the tensor vali palatine muscle. We haven't discussed this, and that's really for something if you really wanted to specialize in this. And that's the muscle that's responsible for opening the eardrum. And it's under the medial pterygoid. When it's in spasm, it compresses the tensor vali palatine muscle and prevents that from happening. So it causes ringing in the ear. The other thing that is associated with ringing in the ear is trigger points to the SCM. So that's something we do know about, right? The SCM. What is the SCM? Brian, what's the SCM? What's the name of the muscle? Sternocleidomastoid muscle. Where is it? It inserts where? Where is he saying it inserts? Mastoid process, yes. Where does it originate? And? Sternum. Very good. What nerve innervates the SCM, Joe?
That. Damn it.
Wait, Jade is chomping at the bit. Jade,
Yeah, take it.
What nerve? Which one? Cranial nerve 11, and cranial nerve 11 is what? Okay, and what does this SCM do?
Rotation opposite side.
Unilaterally, it does what, Joe?
It does like side bending to that same side and rotation opposite side.
Good. And bilaterally?
Flexion.
Flexion, right? So if you're in a forward head position, is your cervical spine flexed? Yeah. Okay, so you could see how this all relates to one another. That's the beauty of knowing what these are and where they are. Okay. First, so you could have tingling, you could have dizziness, you could have headaches. Why do you have headaches? You have that forward head posture, right? Some people that wear bifocals or other types of glasses, what do they have to do with their head when they're in a forward head posture? They have to do a posterior cranial tilt. When you do a posterior cranial tilt, you're compressing all the occipital nerves. And in some sense, you have compression on the which artery? Vertebral artery. And the vertebral artery is associated with signs and symptoms, which we refer to as what? 5Ds. And is one of those Ds dizziness?
Yes.
Okay. Tingling and numbness. We could have tingling and numbness. We could also have referred pain and tingling and numbness from muscles. Didn't we say we do have referred pain all over the body from tingling? From muscle spasms, right? So I gave you an example last semester, very simple one for you to remember, that you could have a trigger point associated with the supraspinatus that mimics what? Anybody remember what condition it mimics? So if you have a trigger point to the supraspinatus, supraspinatus is innervated by what nerve? Suprascapular. Suprascapular nerve comes from what part of the brachial plexus? C5 and 6. C5 and 6 dermatomes. Dermatomes.
C5, C6.
What can trigger points of the supraspinatus mimic?
Herniated artery syndrome, something like that, or something there, lateral epicondylitis.
Lateral epicondylitis. okay? So you could have problems with the trapezius, because the trapezius goes all the way up, right, doesn't it? Nuchal ligament, C7, all over here. You guys, it's coming back? Is that why you're smiling? Okay. It's a good review though, right? Okay. So these muscles all refer to other places too. And I tell you this because I did a year's training with someone who was, Jeff Mannheimer, his name was, Dr. Mannheimer, specialist. I mean, he's amazing. He's a guru for TMD. And I did a year's training under him at the dental school. And there was a gentleman that came in, did I tell you this last semester? There was a gentleman that came in that was edentulous, or that was borderline edentulous. Now, edentulous means you've lost all your teeth. You took all your teeth out. But he had some. He had some. And he was a good-looking man, and he was a young man. He was in his 40s. He was some kind of a stockbroker or something from Manhattan. But he came in complaining, you know, he wanted to have dentures and everything else. And the little bit of the teeth that he had left, he wanted removed. So he had gone to a lot of dentists, and the dentist had, every time he went, he said, I have a pain here in my molar, I have a pain in my incisor, I have a pain in my central incisor, and they pulled it out. Even though they looked at it and said, it's normal, and we can't find anything wrong, he said, it's killing me. I know there's something wrong in the tooth and blah, blah, blah. And I guess he went to enough people that the people just said, okay, let's give this guy what he wants because he's in a lot of pain, so they pulled out his teeth. So when he came to the dental school, this gentleman I had been working with said, it's got to be referred, and it was. It was referred to pain in the cranium, pain in the masseter, pain in the SCM, spasms I'm talking about, like trigger points, from all the muscles around the cranium. And that's why he felt like he had pain in his teeth. So they worked with him. They got him some dentures. He was able to wear some, but yet he still complained of all this pain. Then we followed him. You know, of course, we asked him, what do you do for a living, all this kind of stuff, stockbroker. He got a little bit more, there were a group of people that were working on him, one of which were social workers and psychologists. And through all this treatment that he had, we found out that he was miserable in his job. He was working 18 hours a day. He was married to someone he hated. You know, all these other issues, so he was just clenching and clenching and clenching and clenching all day long. So, of course, they did what they can. They treated him. They gave him some muscle relaxants and all this other stuff. He got to a point where he was functional. And then he came back to the clinic about a year later. I didn't recognize him. He looked absolutely wonderful. He was in an attire. He looked bright. He stood up. So I said to him, what happened? And he said, I left my job. I divorced my wife. I'm doing something I love to do, and I have no pain. So think about all we do as far as stress and clenching and everything else that may cause us to have problems. All right? And think also about it. If, I've been there myself, where I've been clenching over time or something, and I've gone to a dentist and said, is there really something wrong with that tooth, or is it my muscle? I mean, I don't know if any of you have ever had long-term dental care, but if you have your mouth open for a long period of time, what do you feel after that? And sometimes it lasts days. So just keep that in mind if somebody comes into you with a problem. All right. So we have a vertical opening. The mouth opens. A normal vertical opening is about 40 to 45 millimeters. Millimeters, not centimeters. because remember, we're not rhinoceros. Millimeters, 40 to 45 millimeters. Although 35 is acceptable as functional. Women have a larger vertical opening than men. And I don't want somebody saying to me, well, that's because women have bigger mouths. Why do you think that is? Because women have ligament laxity. So our vertical openings are usually larger. Okay? We have lateral excursions where we move from the right to the left. And the lateral excursions are 10 millimeters to each side. And how do you measure a lateral excursion? How do you measure any of this? You would have to have a little goniometer or a little paper, I don't know if I have any, but I'll see if I could find them, where you line it up with the tooth, or you could have a goniometer or a ruler. And you line up the central incisors on the top teeth with the central incisors on the bottom teeth. And you ask a person to open. And when you look at the lateral excursion, you have the ruler this way, horizontal. And you line up the central incisor with the top and the bottom, and you ask a person to do lateral excursions to the right and to the left. Okay? And protrusion and retrusion is about 5 millimeters. So these movements should be smooth and they should be symmetrical. They should open their mouth and not deviate or deflect to one side. Okay, so when you open your mouth, it should be a nice, smooth, vertical opening. Okay? Now, before, we talked about, earlier this morning when we first got here, we talked about these joint compartments. And we said we have a superior joint compartment and an inferior joint compartment. The movements associated with what's going on in the superior joint compartment are translatory. They're translation. And the movements that are associated with the inferior joint compartment are rotation. So when I explain this to a student, I say, think about the fact that you have to turn a doorknob before you open the door. So you have this rotation followed by this translation. So the jaw rotates, right? You guys looking at me? So the jaw will rotate before it translates. Okay? That's what happens in the mandible. Rotation and translation. So if you notice somebody is an early translator, then where do they have problems?
The superior aspect of that joint.
If they're an early translator, then they have problems with rotation, right? So if they have problems with rotation, they have a problem with their inferior joint compartment. All right? Yes?
I'm confused.
Now let me tell you, I could kind of show you. I'll show you without the mask. If you're watching, if you want to assess that, so you ask somebody to open their mouth, they open their mouth. But if you want to assess if they're an early translator, they will do this. Ken, I'll stand here so you can see me first, and then I'll go over there. If I'm an early can you guys all see me? So if I'm an early translator, what I'll do is when I open my mouth, I'll do this. Do you see it didn't? It was no. You just see up and down now, right? But if I do this, did you see how my jaw came out before I opened it? That's an early translator.
Huh.
Okay, so you know that there's a problem with rotation.
So
Could you guys see that?
What it seemed like, right?
All right, do it again. So here I'll just open and close my mouth, normal. Now I'll do it if I'm an early translator. Wait. Did you see how the jaw went out? Okay. But these are really, really specific little things that you have to watch for. And quite honestly, you know, this takes you'll be working in facilities where maybe some people do this, but a lot of therapists don't know this. So you just might be, you just might be one of the people that notice this and say, I think there's something going on in the jaw. You don't have to know specifically what to do about it at that time, but there's something wrong. So what do we do with these people that have problems? Well, we won't go into the whole exercise regimen because that's well beyond this course. But you do provide them with exercises, you tell them certain things, like if somebody is a bruxer or a grinder, you tell them to perform certain things and not do things like, if they have a large vertical opening, you say, don't eat apples, don't eat bagels. If they have hypertonicity of the mandibular elevators, you say, don't eat a bagel, don't eat a roll, don't eat these things where you have to really clench down on it and activate these muscles. So there are things that you tell a patient, but they're all exercises like isometric exercises that you do. And you also refer these people for an orthopedic appliance. Okay? You can't. What's the difference in getting an appliance where a dentist will actually measure you, or getting an appliance, you guys play football, some of you, right? And you have those things that you could heat up and put in your mouth, right? So what do you think the difference is between those two?
One for impact, one for correction.
Okay, the difference is that the one that you heat up is not made specifically for you, and it can cause your teeth to move. Okay, so you have to get a specifically made, molded, you have to get a mold formed, and the physician will then make an appliance out of it. Now, knowing what I said from before, Andrew, you missed some things about, he'll fill you in. Knowing what I said, I mentioned some things before about grinding and sleeping, etc. If you were going to order an orthopedic appliance for this person, which would you think might be better? Now, you're not going to make that decision. It's going to be the physician making the decision, right? But which do you think might be better? A mandibular or a maxillary? Anybody?
Throwing my hat in for maxillary.
Yeah,
You
like
go with maxillary. Why do you say that?
It's not the movable jaw. It's
Yes.
not the movable bone.
Yes. I would go with the maxillary because the mandible moves a lot during the night. The maxillary will stay stationary. Okay? And those appliances, or those orthopedic appliances that they're called, and some people just call them splints, right? Mouth guards or mouth splints. Those appliances are there to decompress the joint. All right? And they really have to be done by somebody who knows what they're doing, because you don't want to cause a bite problem, especially something like an anterior open bite. Okay? All right. So lateral excursions, protrusion, movement should be smooth, translatory and rotatory movements. Translatory movements come from the superior joint, rotatory movements come from the inferior joint. So again, the jaw rotates before it translates, right? The mandible rotates before it translates. So if we are an early translator, then we have a problem with rotation. Yes?
Is there such thing as an early rotator?
I'm sorry?
Is there such thing as an early rotator?
No. I've never seen an early rotator. Not to say that there's no such thing. I've never seen it. Okay, we need to also palpate and auscultate. What does auscultate mean? Listen. So we're going to listen for joint sounds. We're going to palpate the joint. And how do you feel the joint? Anterior to the tragus. You ask the patient to slightly open. You feel. All right? You ask them to open. What's the normal vertical opening? About 40, 45 millimeters. You ask them to open. You look for symmetry. You look at their incisors, their central and lateral incisors on the top, and the mandibular and the maxillary area, and you ask them to open. Okay? So bruxism will overload the joint because you're compressing the joint. So a bruxer, and there's also, did we go into the lateral pterygoid muscle last semester?
Touchdown.
You guys remember? We didn't do that?
Yeah, I don't remember.
The
seeing
lateral
that.
pterygoid muscle actually attaches to the disc. So the lateral pterygoid, if it's overloaded, can actually pull the disc out of place. Okay? So bruxism can overload the joint, and depending on, because the lateral pterygoid is involved in those lateral excursions, and it can if that's overloaded, it can cause that disc to come out in a anterior medial fashion. Because usually the disc comes out in a anterior medial fashion. All right. The difference between deviations and deflections. I'll show you a picture of it. But a deviation can be secondary to a muscle imbalance, or else something known as an anterior disc displacement with reduction. So you could have a disc displacement that becomes reduced, meaning that when I open my mouth, the disc goes back to where it needs to be, and when I close my mouth, it comes out of place. All right, that's just what an ADD with reduction is. Okay. A deflection is when you have a decrease in the normal vertical range of motion. So instead of maybe 40 or 45 millimeters of opening, you only have 25 millimeters of opening, and the jaw goes off to one side because the disc is in the way and won't let it open. Okay? So if you have an ADD with reduction, or an anterior disc displacement with reduction, then the opening click, because you'll hear clicks, the opening click is when the disc is reduced, so the disc goes back to where it needs to be, and the closing click is when the disc is displaced again. And if you work with these people, you'll hear this. Okay? You'll watch them open their mouth, and I'll show you again a picture, and then I'll try to demo it, but there's a difference between a deviation and a deflection. So you see how she's using a ruler, and she's using the middle of the central incisors. So the central incisors from the mandible to the central incisors of the maxilla. And you're opening and you're measuring the millimeters of movement. Okay, everybody's different. Okay? So people say if you have 2 or 3 fingers, that's normal movement. 2 or 3 fingers that you could put in your mouth like this, but we don't do it that way, we actually measure. All right? So normal opening here, it says 40 to 55, that's a little excessive. 45 is actually pretty much the norm.
You said 35 is functional, right?
35 is functional, still limited though, but it's functional. Because think about, you have to open your mouth to eat, right? A lot of the patients that I had gotten, because of their stress level, they couldn't even open their mouth. Maybe they had like 5 millimeters of opening. How do you eat? Or they had a neurological disorder, neuromuscular disorder. So I would have to go in and do joint mobilizations. So you'd have to do intraoral mobilizations. You could do extraoral mobilizations too, but I'd have to do intraoral mobilizations to get them to open their mouth so they could eat. Otherwise, they're stuck with a feeding tube. I'm sure some of you know people that have had a broken jaw. Anybody?
Yeah.
Know anybody who has a broken? What do they do when you break your jaw?
Get a
They
wire
wire
shut.
it,
Yeah.
right? They wire it for 8 weeks, 10 weeks, 12 weeks, depending, right? What happens after you take them off? It's just like putting a cast on your leg. If I put a cast in my leg in plantar flexion for a long period of time, what would happen? I would lose dorsiflexion, right? So you put these wires on somebody, they lose their vertical opening. So over time, you get this adaptive shortening of the muscle. So we have to gently go in there and do mobilization techniques to get the jaw open. Okay? So lateral translation, again, we go from the central incisor from the mandible to the central incisor to the maximal, from the mandible to the, come on, guys. This.
If you don't know it, I definitely don't.
Maxilla, thank you. Maxilla to the mandible, okay, the central incisors. And then you measure the distance. Okay? So here's a deviation on opening. She's opening her mouth, she gets to about, I don't know, maybe 20, 25 millimeters, and she deviates. Which way did she deviate? She deviated to the right, and then she had full opening. All right? And this was also associated with a click. So she had a muscle spasm and she had a displaced meniscus or a displaced disc. So she deviated to the right and then came back to midline. So if it's an anterior disc displacement with reduction, this is what you'll see. Okay? Anterior disc displacement with reduction. You'll see a deviation and then a return to normal. And it's often associated with these clicking sounds. All right. So here's the difference between a deviation and deflection. And I always remember it by the V, or initially when I started, the V in deviation, because you open your mouth, it goes off to one side and it comes back. So think about that V. All right, that's a deviation. A deflection is when you open your mouth and the jaw goes off to one side and doesn't come back. And you have a limited range of motion. Because the disc is in the way and won't let the jaw completely open. It deflects. Okay. So a common sign of ABD without reduction is deflection. Common sign of ABD with reduction is clicking as well as deviation and full range of motion. All right. Oh. So that's a normal joint, right? Looks like pretty normal to you. Has a nice picture of a mandible and the temporal bone and the disc between. So here would be your superior joint compartment. Here would be your inferior joint compartment. What happens at the superior joint compartment? Translation. What happens at the inferior joint compartment? Okay. Here's an MRI. You can see this disc is posterior displaced. You could see this disc is anterior displaced. Here's the mandible. Right? Anterior dislocation of the disc is right there. Here's your condyle. This is where it should be. So this is all retrodiscal tissue right here. That's painful because that tissue is highly innervated. All right. So what do these muscles do? We know that the medial pterygoid bilaterally elevates the mandible because it's an elevator. So it also protrudes, causes protrusion. But unilaterally, it makes the jaw move to the opposite side. So when it unilaterally contracts, it makes the jaw move to the opposite side. The temporalis, bilaterally, will elevate the jaw and protrude the jaw, but unilaterally, it makes the jaw deviate to the same side. That's just what these muscles do. And the lateral pterygoid, which attaches to the disc, bilaterally will open the jaw, so it depresses it. It protrudes the jaw, and unilaterally it causes the jaw to move to the other side, the mandible to move to the other side. That's just what the muscles do. Yeah, I put these in here just for a fact. Yes?
So if somebody had deviation to like the right side, for example, how would you know whether it's the medial pterygoid, the left medial pterygoid, or the right intertemporalis, like causing that deviation?
Causing the protrusion?
Like the lateral deviation to the side. You said one does opposite side, the other one does the same side, but how would you know which muscle is responsible for that?
How would you know which muscle is responsible for what?
So like if somebody had lateral deviation to the right, how would I know if the left medial pterygoid is weak or if the right
Oh, I see what you're saying, I see what you're saying by palpation. Yeah, and by testing. Yeah. So I test the strength and I would palpate. All right, so the digastric muscle depresses the mandible. It opens the mouth. So when we do lateral excursion to the right though, because of what the muscles do individually, when we move to the right, it's the left lateral and medial pterygoid that are doing it, as well as the right temporalis. Those are the muscles that are causing that to happen. Yes?
How do you find the left, I'm sorry, the lateral pterygoid? So the medial is underneath the angle of the mandible. How do you find the lateral pterygoid?
Intraorally. We're not going to do that.
My old
Okay.
clinical director used to treat TMJ or TMD
We got a
pretty
guy,
frequently, and he would do like intraoral, like manibs.
Yeah.
It was pretty cool. The
Yeah.
manual works pretty
When you do intraoral mobilization and intraoral palpation, you have a patient sitting, or you can have a patient lie down. A lot of times I have a patient sitting because it's easier to work with their jaw. And then you stabilize your head and you stand on the opposite side of whatever you're... So if I'm going to mobilize the left, I'll have them and I'll stabilize their head and I'll mobilize them this way. And I'll do some long axis distraction and some posterior tilt and then some medial glides. Because a medial glide with distraction will capture the disc because the disc is out in anterior medial direction. So by pushing down and pulling forward, sometimes that's all you need to capture that disc.
Do you do any work on like C1, C2, those upper cervical levels with that?
You can, sure. Yeah, because a lot of times you find that somebody might have a facet problem or cervical spine, certainly. There's something known as the, I don't know, I think I took it out, trigeminal cervical complex. It's a network of
Nerve bundle?
nerves associated with the cranial nerves 3, 5, 7, 9, 10, 11, and 12. It's a network that's associated with problems with the TM. So any of these nerves can be associated with problems and can cause symptoms associated with TM dysfunction. Yeah, so it's complicated.
Yeah,
It is.
the PT I worked with just took her TMD cert, and it was all like a lot of like upper cervical mobilizations and like even into like C1, C2 manibs.
Yeah. Because think about it, I mean, you're talking about rotation and flexion, right? You're talking about what position is the head in. So the position of the head can change what's happening with the muscle. Yeah. Okay. Freeway space. What I want you to do is put your pens down for now. Because some of you are going to find out something about yourself. And sit up straight. And don't think of anything. Just sit there. I don't mean sit up like force yourself. Just sit up straight. What's happening to your teeth and what's happening to your tongue?
Tongue's in the roof of the mouth.
What's happening with your teeth? Are they together or are they apart? Anybody's teeth together?
Mine, I'm kind of touching. I'm trying to do that, I think.
Yeah.
Well, that's why I didn't tell you before I'm
Yeah,
asking,
we
because
just-
now
we
that I'm
just-
telling you, it's a
it's
different
over.
story. And where's your tongue? Bottom? Bottom?
Mine tends to, I've been actively trying to keep it up, but it stays down.
Okay, your tongue should be on the palate, the upper palate behind your incisors. And your teeth should be apart. Normal freeway space is 5 millimeters. That's normal. Okay? So if you say to somebody, if you ask them, well, where's your tongue right now? Especially if you're looking at somebody, and sometimes I did this in class where I'm looking at somebody and I'm looking at the muscles around the face. And I may say, let me see your tongue. Did I say that to you? Can I see your tongue now? Oh. What was I looking for? what Ashka does, I believe that she's stressed at night. I believe she clenches at night. And she uses her tongue to decompress her joint. So she's got ridges on the tongue, more so on one side than the other, which are indicative of something known, it's a scalloped tongue. It's called a scalloped, like the scallops. Scalloped tongue, and it's indicative of somebody who's clenching.
You also said one side of my face is fuller than the other.
Yeah.
Yeah, I can see that.
Oh, you can see that. Yay!
I thought it was because after I got my wisdom teeth out, like, I noticed it after I got my wisdom teeth out. I didn't know
Trying to
it
hide
had
it.
anything to do with it. But, like, I noticed because I had more swelling on one side than the other, and then I'm like, oh, well, that's just permanent now. It's just how it's going to be. But I didn't realize it was the whole,
Yeah,
yeah.
yeah. Because you have some hypertrophy, right? Yeah. All right, interesting?
Grow a beard.
Interesting. Okay.
Hide it.
All right, so this freeway space is normal. 5 millimeters of a freeway space. Tongue should be at the top of your mouth. How many teeth do we have? 2, 1, 2, 3, top and bottom. 2, 1, 2, 3. 2 incisors, 1 canine, 2 premolars, 3 molars.
A lot of that.
Yeah? That's what we should have. That's normal. That's what you're born with anyway. But they yank out your wisdom teeth and everything else. But 2, 1, 2, 3 is the way is the way I remember it. 2 incisors, 1 canine, 2 premolars, and 3 molars. So you could really impress your dentists when you go next time. Say, which is my premolar? Which one are you on right now? My lateral incisor or?
Yeah, but then they say things
Okay.
like lateral bicuspid, and then you're all,
Yeah.
and then I'm gone.
Okay, so normal freeway space. This is normal. I haven't found a better animation than this, even though it's simple. But I think simple sometimes is better. Where's the disc?
It's moving along the fence.
Where's the disc? The disc stays with the mandible, doesn't it?
Yeah.
Okay.
So, all right, I got a weird question. So if
What's this?
displacement of the disc,
Displacement.
What's this?
Yeah, the disc is all wacky.
How does this differ from this?
the disc doesn't go all the way back into the joint space.
The disc is like in front of the condyle.
Is that an anterior disc displacement?
What is this? We just went over it.
Is it an ADD?
It's an ADD with reduction. An anterior disc displacement with reduction, right? Reduces, out, reduces, out, reduces, out. The reduction means it goes back where it needs to be. So what are you going to see with this person? When you look at them physically? A deviation. A deviation. All right? ADD with reduction. What's this? Does it ever come back to where it needs to be?
No.
So this person is going to have a deflection, right? The jaw's going to open and go off to the side. Okay?
Okay. If the superior joint compartment is transitory and the inferior compartment is rotational, what's the disc doing? Is that transitory movement as well?
The disc goes with the mandible. Yeah.
Okay. So it
Yeah.
follows the
Yeah.
mandible, so it's a rotational and transitory motion
Well,
with the disc?
it moves in a backward motion or a forward motion.
Okay.
So it'll move backward during rotation and anterior during translation. Okay? What's this?
That's an anterior open bite.
That's an anterior open bite. Where are people with anterior open bites that can be born this way or can be caused secondary to some poor appliance?
Like a pacifier?
Pacifier.
Thumbs up.
Pacifier thumb suckers. That's why it's not a good thing to do. It causes an overjet and it causes an anterior open bite. How do we know somebody has an anterior open bite? And first of all, what happens when they have an anterior open bite? Where is their tongue? usually on the bottom of
Or
their
the
mouth,
Yeah.
right? They're not at the top of the roof of the palate. When should your tongue be at the bottom of your mouth, sitting in your mandible? A lot of times. Every time you swallow, every time you eat something, it should make space, the tongue should make space for the food to go down, right? So if somebody's got an anterior open bite all the time, then the tongue is down, and proprioceptively, when your tongue sits in your mandible and doesn't come up to the maxilla, it induces elevator muscle activity because it's thinking, I'm going to swallow or something. I'm going to swallow, I'm going to eat something, right? That's just the way we're built. The tongue is at the bottom. So proprioceptively, it induces elevator muscle activity. And so what is this person going to complain about? Somebody who has an anterior open bite. Of pain. Right? How do you know somebody has an anterior open bite? The way you test somebody is you ask them to stand and you look at them from the side and you give them a glass of water. And you ask them to take a sip but not swallow it. So I'll come here first. Okay. Can you all see me here? All right. So if I take a sip and I don't swallow, and now you tell me, all right, take a sip of this water, and now you tell me swallow. They'll do this. To get their tongue out of the way.
So they're not using their tongue? They're using
Because otherwise,
this one.
the tongue will come out. Right? And people that have anterior open bites, did you ever see anybody drink who has an anterior open bite? They put their tongue out. Think about that next time you go to a bar and have a drink. There's plenty of people that have anterior open bites who don't have problems, but their tongue will come out and touch the glass every time they take a sip because they have an anterior open bite. So I showed you guys, this is what it looks like. Take a sip of water, stand here, swallow. Okay? They need to get their tongue out of the way. So that's what you're going to see. And we usually do this in lab, just to see if anybody has an anterior open bite. Because otherwise you'll have to do this and you'll lose all the water.
Just ask them to smile when they come.
Well, okay? So that's an anterior open bite, and those are the things you have to be cautious of if somebody has an anterior open bite. Okay? Early translator we talked about, and then there's postural factors associated with arthritis. You can have arthritis. If you have arthritis, you have hypomobility, right? You have joint degradation. You have decreased synovial fluid. So you have pain in the face, and you have decreased, and you have problems with opening. Okay. Forward head posture, we talked about, causes a retruded jaw. Not only does it cause a retruded jaw, but it causes compression on the spine itself. So the further your head is out, the more force, the more the effects of gravity affect your cervical spine. Okay? And I did a study when I was in this class. I did a study on an SEM. And we had, there was a way to measure the distance from the SEM. And there's a normal and an abnormal, and there was actually a machine that measured the distance. And we found that these people that had these forward head postures had so much more compression of the joint because they did MRIs to look at the compression. So there's a lot of studies out there. All right. This is a whole thing on rotation and translation. Let me see if we can... Let me see if it's still here. It's showing you the disc. It's showing you the rotation. These are stylomandibular ligaments, retrodiscal tissue, ligaments, and the opening and closing. There's a rotatory movement. I don't see it. There. Rotation and translation. So you get the rotation before you get the translation. Okay? here.
You might wanna just hit the PowerPoint on the bottom of the screen.
Yeah,
Is that a PowerPoint icon on the bottom? Just click on that. There you go.
Okay. All right, we talked about forehead posture and posterior cranial rotation. We talked about tooth contact. I said that there is a compression of the trigeminal cervical complex, which is a combination of these nerves, cranial nerves 3, 5, 7, 9, 10, 11, and 12. Hold on a second. And you could also have, that will increase your joint compression, and it'll also pull on the retrodiscal tissue, and any problems with that that are arising from the cervical spine will also have, will induce hyperactivity of the muscles. Yes?
Just from the animation, that's still the convex concave rule, right?
Yes.
Okay. No modify.
Okay, forward head posture, posterior cranial rotation. Intracapsular is within the capsule itself. So if there's something intracapsular, we have to look into the capsule and see what's going on. Extracapsular is more muscle involvement. Okay? So muscle and origin. So intracapsular, we can get some fibrosis in the joint. We can get some stickiness in either joint. We may need to have a little mandibular mobilization to free up the joint. Okay? Unless it's something that's arthritic and we can't change it. All right. So what's our treatment? We could use heat on these people. If we use heat on these people to relax the muscles, we could use a cervical hot pack. But the cervical hot pack, we wouldn't put on, we could use a cervical hot pack on the cervical spine, but we'd also take a cervical hot pack and put it on this way and attach it under here. So this part of the head heats. So we're working on the cranium and the face. Okay? We could also use ice. So we'll talk about the effects of ice and heat as the semester goes on when we talk about modalities. We could also use ultrasound, which is deep heating. All right, it's one of the deepest heating modalities we have. And we could use it in a pulsed form, which is non-inflammatory. We always provide postural correction, as well as diaphragmatic breathing exercises, because when someone doesn't breathe diaphragmatically, what happens? They get hyperactivity of everything here, right? Hyperactivity of the scalenes, hyperactivity of the SCMs. These muscles become hyperactive and cause more problems. So cause even more of a forward head posture. And what happens if we get hyperactivity of the scalenes? What else can we have? Thoracic outlet. Yeah. So a lot of things can happen just because, it's not as cut and dried as you're looking at somebody and it's one thing. If somebody's got this, very rarely is it just, okay, unless they've had an accident and it's a simple matter of you've had a mandible that's been wired for a long time. These people become very complicated. They also have a lot of, you never know when you're working on somebody's head. I had been working on somebody's head one time. It was a young woman, and she came from the Women's Center. And when I was working on her head, I was doing some craniosacral, because I did a lot of craniosacral work with mandibular mobilization. And she started to cry hysterically. And no one knew that she was brutally raped. And she didn't want to tell anybody because she felt like it was her fault. She felt like women were second-class citizens and blah, 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 and there was a whole big problem with this. So I had to refer her out to social services. But, people will tell you, I told you, when you touch people, they tend to tell you things. So just be aware of that, because this is not within your realm to treat these people. I mean, you're treating their disorder, but, you have to get help for them, because otherwise they went. I also had a little girl, oh my God, she was the sweetest thing. She wasn't a little girl, she was about 21, but there was mentally something. She used to sing Crazy. You know that song, Crazy? It's an old song. But she used to sing this all the time, and she did tap dancing, and she did ballet dancing. And she did it with like 5-year-olds, but they put her in a class with these, because she was very happy doing this. And I just couldn't get her jaw, I couldn't get it open. And then through one of the sessions, she had admitted that she was being abused at home. So, you know, a lot of things can happen and you have to be able to handle these things. So joint mobilization. And finally, what do I say to somebody who does a lot of clenching? Especially when they're driving, because they're standing there and they're driving a car, and they get nervous in traffic. What do you tell somebody? Cluck. When you cluck, you decompress the joint. And the TMJ mantra is tongue up, teeth apart, lips together. Okay? Sometimes very difficult for some people to do. But the clucking is something they always remember. And, you know, years ago, they may have said, oh, somebody's going to look at me and think something's weird because I'm clucking. Nowadays, you know, you drive a car, anything goes. Usually somebody's on the phone, somebody's this. So if you're clucking, I mean, if that's the only thing you can get somebody to decompress that joint without, because when you don't know, you don't think about it, it becomes so normal to you to clench that you don't even realize you're doing it. So, that's it. Okay? And you can look at this, it's just the MJ movement, it's the whole video. Okay. All right, what will I hold you responsible for in the test? Not much. Okay, not much. Does that mean I don't want you to look at this? Because this was really last semester's material. I still want you to look at it. I will ask you about muscles primarily because that's what they will ask you on the state board. You know, and what's normal opening, what's normal excursions, stuff like that. They have not asked anything, because it's a specialty. They have not asked anything about anterior displacements with reduction or, you know, but just in the event, I'm not saying they won't. So, you know the difference between a deviation and deflection. You know, but this is difficult. It's difficult. So just mull it over, look at it. If you have questions, we'll talk about it next time. Okay? All right, let's go to lab.
And I'll call him back.
See ya. See you later. See ya.
They shouldn't. They shouldn't. There's no reason. Dude, that, I saw it. Come on.
Yes, please.
Oh, wow. SMOL. No, dude, don't try it. Don't do it. It'll shrink.
Those of you who want to go to your cars or go get something to eat outside or something that are not in the second lab can do so. Otherwise, you could stay in here and do some reviewing or something.
Exactly, it's literally all they do. You're like an hour. They do that band watch. Yeah, exactly, band watch all day long. Yep. Just the whole sentence, just the whole sentence. Exactly, so yeah. But I did notice, when I started doing that, my squat, Scotty.
I like thought about it, but I was like, I think I will.
Oh, I went Subway.
much time? We got time, right? Oh, we got time.
Keep in mind, there is snow on the ground. Snow is on the ground, I might have traveled.
Oh yeah, started doing that thing.
I got to see Rich.